Welcome back to the deep dive. Today we are tackling one of the most critical and honestly terrifying cardiovascular emergencies there is, aortic dissection.
Yeah, it's a big one.
We've got a stack of really dense, expert-level clinical material here, the kind of stuff you'd see in an emergency department guide where decisions have to be made in, seconds.
And our mission really is to boil all of that down, to turn this complexity into clear, understandable knowledge for you.
Right.
Because this isn't just about memorizing definitions. It's about understanding a catastrophic mechanical failure. We're talking about the body's biggest artery, the main pipeline coming right out of the heart.
A super highway, really.
Exactly. And it's under incredible pressure. So when that fails, every single organ in the body is immediately at risk.
That's the perfect way to frame it. If the main pipeline breaks, everything downstream just stops. So let's start there. Let's unpack the anatomy of this accident. When we say aortic dissection, what are we actually describing?
Okay, so think of the aorta not as a simple tube, but as a pipe made of three distinct layers. You have the inner lining, the intima, then the strong muscular middle layer, the media, and finally the protective outer layer, the adventitia. A dissection starts with a tear, usually a small one, in that very inner layer, the intima.
So that little tear is the point of failure, the entry point.
Precisely. The blood is being pumped out of the heart at, immense pressure. Once it finds that tiny tear, it forces its way into the wall itself. It starts to peel the intima away from the media.
It literally dissects the layers apart.
That's where the name comes from. And this is the core problem. It creates two channels where there should only be one. You have the original proper channel, we call it the true lumen.
Okay.
And then you have this new dangerous channel inside the wall itself, which we call the false lumen. It's basically a high-pressure pocket of blood where it absolutely shouldn't be.
And it's worth mentioning, the notes point out this is part of a bigger category, right? Acute aortic syndrome.
Right, yeah. There are a couple of important variants. One is an intramural hematoma, or IMH, that's basically bleeding inside the aortic wall without a clear tear you can see.
So like a bruise inside the artery wall.
A very dangerous bruise, yes.
Oh.
And the other is a penetrating atherosclerotic ulcer, or PAU, where plaque buildup erodes deep into the wall and lets blood leak into the media that way.
So it's a whole spectrum of aortic wall failure.
It is. But they all share that same terrifying potential. Rupture or cutting off blood flow to vital organs.
So once you know a dissection has happened, the immediate question is, where? Location is everything.
Location, location, location. Absolutely. And for that, we need a quick, simple map, a way for doctors to communicate the urgency.
Which brings us to the classification systems.
Exactly. And the most important one, especially in an emergency, is the Stanford classification. It's simple, it's binary, and it tells you what to do right now.
So let's break that down. What is a Stanford type A?
Stanford type A is the one that sets off all the alarms. It means the dissection involves the ascending aorta. That's the part of the pipeline coming right off the heart.
The very beginning of the system.
Yes. And if the ascending aorta is involved, it is an immediate life-or-death surgical emergency. Full stop.
Why? What makes that specific location so much more deadly?
It's the neighborhood. The ascending aorta lives right next to two critical structures. First, the aortic valve itself. A type A dissection can wreck that valve, causing it to leak horribly. Blood floods back into the heart and you get instant catastrophic heart failure.
Wow.
Second, the coronary arteries, the tiny vessels that feed the heart muscle. They branch off right there. If that false lumen squashes them shut, the patient has a massive heart attack on top of the dissection.
So type A isn't just about the aortic tear, it's about the immediate lethal damage it does to the heart itself.
That's it. Now compare that to a type B. A type B dissection starts farther down the pipeline after the arteries that go to the arms and head have already branched off. It's in the descending aorta.
And that distance from the heart is key.
It's a huge factor. It's still incredibly dangerous, don't get me wrong, but it often gives us a little more time. It means we might be able to manage it aggressively with medications first.
The notes also mention the DeBakey classification. Is that important to know?
It is, but it's more for the surgeons. If Stanford is the emergency map, DeBakey is the detailed architectural blueprint. It gives a more precise location of the tear for planning the actual repair.
Okay, that makes sense. So now we know what it is and where it can happen. Let's talk about why. What are the risk factors that weaken this massive blood vessel in the first place?
The main culprit, the #1 cause by a huge margin, is uncontrolled hypertension.
High blood pressure.
Chronic high blood pressure. It's just years and years of relentless, abnormal force hammering against the inside of that aortic wall. That constant stress makes the intima brittle, weak, and eventually it tears.
It's just a matter of time before the weakest spot gives. But it's not just chronic wear and tear. The sources list some acute things too, like cocaine use.
Right. Cocaine causes this massive, sudden spike in both heart rate and blood pressure. It's like a pressure bomb going off inside the arteries, and it can literally rip the aorta.
And pregnancy is on the list too, which is surprising.
It is, but it makes sense when you think about it. You have hormonal changes that can weaken connective tissues, plus all the intense hemodynamic shifts of late pregnancy. It's a rare but known risk.
Beyond pressure, there are also sort of inherent design flaws. You mentioned genetic conditions.
Yeah, conditions like Marfan's disease or Ehlers-Danlos, these are disorders of the body's connective tissue. For these patients, the media, that strong middle layer of the aorta, is just inherently weak. It's fragile from birth.
So they don't need years of high blood pressure to cause a problem.
Exactly. Their aorta is already vulnerable. And we should also mention inflammatory conditions like Takayasu arteritis, which is a type of vasculitis where the body's own immune system attacks and weakens the large arteries.
That's a really complete picture. Okay, let's shift to the patient. What does this feel like? What are those classic unforgettable warning signs?
The absolute hallmark is the pain. This is the big teaching point. The pain isn't gradual, it's sudden. It hits peak intensity almost instantly. And patients describe it as ripping or tearing.
That's a very specific description.
It is. And crucially, it radiates. It often starts in the chest and feels like it's boring straight through to their back, right between the shoulder blades.
So sudden tearing, chest to back pain, that's the huge red flag. But then there's a physical finding that's almost a dead giveaway.
Yes. This is where you can really see the false lumen causing problems. We're talking about asymmetric blood pressure or pulse.
What does that mean?
It means that the false lumen, this ballooning pocket of blood on the wall, is squashing the arteries that branch off the aorta, like the ones going to your arms.
So if I check the blood pressure in your right arm and then your left, they could be wildly different.
Wildly different. We're talking a difference of 20, 30, 40 millimeters of mercury. Or you might feel the pulse in one wrist is much weaker than the other, or even delayed.
That's a clinical slam dunk then. It's direct evidence that blood flow is being blocked.
Exactly. It's evidence of malperfusion. The false channel is starving parts of the body of blood. And that explains the devastating complications.
Let's list those. What happens when that flow gets cut off?
It depends where. If the dissection hits the arteries going to the brain, you get a stroke. If it blocks the coronary arteries, you get a myocardial ischemia, a heart attack.
Okay.
If the arteries to the gut are compromised, you get mesenteric ischemia, which is incredibly lethal. You can lose blood flow to the legs, causing limb ischemia. And as we said with type A, you can get acute aortic regurgitation and sudden heart failure.
It's a cascading disaster. So a patient comes in with this story. The clock is ticking. What's the immediate workup?
You start with the basics, fast. You get an ECG to rule out a more standard heart attack.
Oh, yeah.
And you get a chest x-ray.
Does the x-ray show the tear?
No, but it can give you a big clue. You look for something called a widened mediastinum.
The space in the middle of the chest.
Right, the area between the lungs where the heart and aorta live. If that space looks abnormally wide, it's a huge hint that the aorta might be dissected or leaking blood.
And what about blood tests?
You'll check troponins for the heart, for sure, and you'll check a lactate level. If lactate is high, it's a very bad sign that major organs, like the gut, aren't getting enough blood.
But these are all just clues. To get the definitive answer, you need better pictures.
You need advanced imaging, and you need it now. That means a CT scan with contrast, an MRI, or a transesophageal echo, a T.
And what's the goal of that scan, the aha moment?
The goal is to see everything. You need to find the intimal tear, see the flap of tissue separating the two channels, and most importantly, you have to distinguish the true lumen from the false lumen.
Getting that right must be absolutely critical for the surgeon.
It's paramount. You have to know which channel is the original intended pathway. The false lumen is often bigger but has slower, more stagnant flow. Getting that wrong during surgery could be instantly fatal.
Okay, so let's move to the action plan. Dissection is confirmed. Management is immediate and aggressive.
Instant and aggressive. The patient goes straight to an ICU or a cardiac care unit. They're on complete bed rest, nothing by mouth, getting oxygen, and are hooked up to every monitor we have. And first up, aggressive pain control.
Why is pain control so high on the list? It feels like you'd be focused on the vessel itself.
Because the pain is part of the vessel problem. Severe pain causes a massive adrenaline surge. That surge spikes your heart rate and your blood pressure.
Which puts more stress on the tear.
It literally drives the dissection further. It's like pushing the accelerator in a braking car. So stopping the pain isn't just for comfort. It's a mechanical necessity to protect the aorta.
Which leads us to the golden rule of management. What is the absolute #1 priority?
Aggressive blood pressure and heart rate control. You have to slam the brakes on the system. The goal is to reduce the physical force, the sheer stress that's ripping that aortic wall apart with every single heartbeat.
And we're not just talking about getting it down a little. The sources give very specific, very low targets.
Extremely strict targets. We aim for a systolic blood pressure between 100 and 120, and we want the heart rate down between 60 and 70 beats per minute. That's slow and low.
How do you achieve that so quickly?
The first-line drugs are IV beta blockers. Something like labetalol is perfect because it does both jobs at once. It lowers the blood pressure and slows the heart rate. It's the ideal tool for this.
And what if that's not enough to get the blood pressure down into that tight window?
Then you can add a second agent, usually sodium nitroprusside. It's an incredibly potent drug for lowering blood pressure. But there's a huge warning here.
What's that?
You can never give it by itself. If you just drop the blood pressure, the heart will try to compensate by beating much faster. That's called reflex tachycardia.
Which would make the dissection worse.
Exactly. So you always give the beta blocker first to control the heart rate, and then you add the nitroprusside if you still need to bring the pressure down further.
So once the patient is medically stabilized, we go back to our Stanford map to decide on the definitive fix. Type A versus type B.
Right. It all comes back to that. For type A, involving the ascending aorta, the fix is immediate open heart surgery. There's no other option. They have to go in, cut out the damaged section, and replace it with a synthetic graft.
And type B, the one further down.
For an uncomplicated type B, you often continue with aggressive medical management. But if it needs intervention, say if it's causing malperfusion, the repair is usually less invasive. We can often do something called TEVAR.
What's that?
Thoracic endovascular aortic repair. A surgeon threads a catheter up through an artery in the leg and deploys a stent graft inside the aorta to cover the tear and reinforce the wall from the inside.
Much less invasive than cracking the chest open.
A whole different ballgame, yeah. But the choice is always dictated by the anatomy and whether vital organs are being starved of blood.
Okay, we have covered a huge amount of ground here. Let's recap the absolute must-know points for you. Aortic dissection is a tear in the aorta's inner lining, creating a dangerous false lumen. It's mostly driven by chronic high blood pressure.
The key signs to remember are that sudden, severe tearing pain that goes to the back and the finding of a different blood pressure or pulse in each arm.
And the life-saving first step is always rapid, aggressive control of blood pressure and heart rate in the ICU, using 5V beta blockers as your primary tool.
That's the core of it right there.
Now, we spent some time on how critical the imaging is, making sure the surgeon can tell the true lumen from the false one.
Yeah.
The sources raised a point about this that gives me pause, and it's a good final thought to leave you with.
Yeah, the notes mention that sometimes, even on a high-quality CT scan or an echo, it can be really, really hard to tell which channel is which, especially if the true lumen is severely compressed. So in that moment, with the patient on the table and seconds counting, how does the team handle that uncertainty? How do they navigate that subtle but potentially fatal challenge of telling the true path from the false path when the pictures aren't 100% clear, and knowing that putting a cannula in the wrong lumen could cause an immediate fatal rupture?
It makes you think about the limits of our technology and the immense pressure of human judgment in a crisis.
It really does. Something to think about.
A profound point to end on. Something to mull over until our next deep dive.
Stay curious. Keep learning.